I've got a couple of questions I wanted to tee up to the panel. The first is interesting to me, right? Like our focus for the most part has been, surgeon-owned freestanding ASCs in the United States. So Dr. Corten, what's going on across the pond when it comes to ASCs, outpatient clinics? Give us a little bit of perspective there.
Yeah. So Russia is very close to Europe. That means the communists are very close to Europe. In other words, we have a completely different culture. But I think that the ASC market is coming up. It is clear that in Europe also we're struggling a lot with costs in healthcare. And in one perspective, they're also trying to bring down the wage of the surgeons and trying to make us, how do you say that, people who work with the government, servants for the government. On the other hand, they realize that if they want to keep up with the quality of care, that they need to open up the private healthcare system. And what we see in countries like, I think, Germany, in the Netherlands, it's already happening, and obviously in the UK as well. In Belgium, for example, we feel that things are shifting in the same direction. And I think we as surgeons, we learn a lot from what you guys are doing here in the States. And I think we need to look, we also need to look to the same horizon as what you guys are doing here now. I love Charlie's talk, obviously, about the efficiency. What we are now doing is we're preparing ourselves within the hospital.
Got it.
Within the hospital to why do I do 14 hips? Why would I do it? There's no reason, but I want to be prepared to, when it opens up,
To make the jump.
Make the jump. It is coming. It is coming for sure.
Yeah.
Yeah.
I want to talk, and just throw your hand up if you have any questions, but I want to talk a little bit about kind of herding cats, right? So as you started down this journey, there's a lot of people, a lot of stakeholders that you have to get on the same page, from surgeon maybe as a quarterback, to anesthesia, to nursing, and everybody else in between. So maybe I don't know, Dr. Mayle, tell us about how that journey went for you as far as getting stakeholders aligned, surgeons, physicians, administrative, and anesthesia.
Yeah, we started doing frequent meetings. So we'd have a weekly meeting at first, kind of getting all the stakeholders involved. Fortunately, I had a great administrator who was. She was kind of our quarterback, because she won the cases because she saw the dollars there. So we have a medical director that's an anesthesiologist, myself, her, and then we had the head of nursing. So we would meet, discuss, and then evolve. So
yeah. Anybody else have thoughts on kind of creating alignment and working through that? Yeah.
To copy Dr. DeCook, it's about alignment, right? It's about everybody having the same goal, everybody knowing the goal. Everyone in the center should be able to say what that goal is back to you repetitively, and also the leader of the ASC, even if you have a managing partner, is always going to be the physician. And the physician has to want to create a team atmosphere and not split those dynamics, right? If you make your team competitive against each other in the wrong way, you split that dynamic. So it has a lot to do, I always feel like, even as a managing partner, with what your physicians are doing in leadership.
Sure.
Charlie, let me ask you a question. What anesthesia that you're using for your hips? Anesthesia that you're using on your hips?
Yeah, we do spinals on everyone.
With mepivacaine?
We're currently doing mepivacaine. Dr. Bradbury has done studies looking at it as well. That lidocaine is probably the best way to go. So we're trying to go that route.
Lidocaine.
Currently, we're doing mepivacaine.
The alignment of teams is much easier done with efficiency. And when Charlie was saying, I'm not paying my team, well, obviously, I was there last year with Charlie, and what I noticed was we see the exact same thing in our hospital as in Charlie's ASC. In my hospital also, why would my nurses do 14 hips? Well, I can tell you, they rather do the 14 hips than 3 total knees in one day. And why is that? Efficiency brings down the variables, brings down also the exhaust for the team, and they have that pace, and they love the pace. That's exactly what you were saying.
It's interesting. Kristoff and I have totally different models from a staffing standpoint. What you saw with Kristoff is one scrub tech and Kristoff doing the entire thing. It's absolutely amazing, right? I mean, if you look at the value you're bringing, I'm paying a lot more staff to help with turnover. I mean, we have 5 or 6 people in a turnover, right? So we devote a lot of staff to that. You do it very efficiently with very minimal staff, so I think we have to start looking at that a little bit closer. For me, I don't want to burn out our staff any more than we already have, so we have lots of people to do lots of functions. But you do it in a fantastic model, and I think we have to, tease out which model's better.
Yeah, I thank you. But the first thing that everybody asks me is, oh, am I going to lose my job? Well, actually, the nurses, no, actually you are not. You're going to do other tasks, and you're going to do them better with more pleasure in your work. So the nurses are, obviously we have a drop in nurses, but they because they are so much involved in the efficiency care plan, they get ownership, they're proud of their job. They go home and they say, wow, we did 16 hips today. Well, I did it and I did it well.
The other thing, I think that's a great point. The other thing is extreme ownership, Jocko Willink, right? Extreme ownership. We had a bunch of scrub techs in the last month, that were interviewed for the job, and I never have to say a word, right? Dr. Bradbury never has to say a word. They filtered them out. Like, they made it a day or two and out they went, right? They didn't fit our culture, right? So it's this culture of excellence, right, that really has to permeate, and it'll self-select itself out, right? People that suck leave, which is a fantastic thing, right? Because we only want the very best, right? That goes to anesthesia. If you suck, if your spinal times take 2 hours, out you go, right? If you can't turn over a room, if you can't hand me the next instrument, and it's not like I'm like firing these people. They're like, whoosh, they just leave. They feel like they can't compete.
Yeah, and one more thing, I think when you bring in new technology in your OR, involve your staff. So they understand why you do it, and they also understand how it would benefit them. I think that's crucial.
I will say that technology still, this is kind of on the theme from yesterday, technology still sucks. The vast majority of our staff hate it when a surgeon's going to do a robot. So you talked about robots. They dread it, right? So the companies in the room need to hear this, right? We may do it, but they dread doing it. It takes a lot of effort to get a robot ready for a case, right? A lot of extra effort for not a lot of bang for the buck. So just keep that in mind.
So wanted to touch on a theme around revisions, right? So if we could maybe go down the line. Dr. Suarez, are you doing revisions at all in the ASC environment? Or your thoughts
I've done
on that?
very simple revisions, but it's not my bread and butter.
Okay.
I'll do them in the hospital.
Okay. Dr. Mayle.
Yeah, I'll do them. I've done hips and knees. I have to look and see what's going to be done and how many trays are going to be used, because that's kind of one of our rate limiting steps.
Yep. Okay.
So of our centers doing total joints, less than 20% of those centers are doing revisions.
Across all of Compass?
The ones that have total joint,
Sure.
right?
Got it. Yep.
Yeah, we're limited by contracts right now, but we absolutely think that's the future.
Okay.
Yeah, in our portfolio as well, revisions are less than 20% of the total.
Okay. Dr. Corten, you ever do revisions at all in your
Yeah, sure, but
freestanding
I don't
ASC?
have revisions of my own.
I know, exactly.
No, sure.
So I wanted to kind of dive into a little bit more, Dr. DeCook, around, you've talked a lot about radical time transparency, 12 by 12. When you're just starting out, that's going to be tough to get to, right? So maybe enlighten us with, like, what were those key maybe gating steps for you, right? Like, how did you get, up to 12 to begin with, and then, 12 by 2, 12 by 1, like, key decision points along the way?
I think your goal can never be, I want to do a certain number of cases, right?
Yeah.
It's never your goal, is that have a big goal. It's always small. And you have to start small by knowing your data, right? If you don't know how long it takes to do a total hip, if you don't know how long it takes to close, if you don't know how long it takes from when you get the patient in the room to when you're cutting, then you don't have enough information to act on, right? We all like to blame anesthesia and say it's anesthesia is a turnover problem, right? Well, you don't know that. And the problem with turnover, using turnover, is there's 8,000 things that can get screwed up in a turnover. The staff, the patient, anesthesia, I mean, you name it, right? Turnover is too big a problem to eat. You have to get to your data first. So I would say step one is know your data, know your time, and then you can start to work on one problem you have, and then move to the next problem, because you're going to have a ton.
Excellent. I think there's a fair number of fellows in the audience, or at least there were yesterday. So wonder if we could just go down the line. Dr. Corten, I'll start with you. Looking back, right, what advice would you give to a fellow, right, that is going to be starting practice, the next 1-2 years, considerations about the ASC or HOPD sort of environment? Any advice you'd have for them?
And in what terms of advice?
Well, just from a practice management perspective, is there things that they need to be thinking about as they're getting going?
I've got some.
Okay.
So
Sarah, go ahead.
this is a moment that I think that these, we'll say junior docs, with no offense, have an opportunity to help their senior docs in a way that they can't always, right? In the hospital space, if you're offered a contract for a hospital and that's the route you'd like to go, make sure you have the ability to own in the ASC or own in an ASC. Some hospitals are opening up to this. I would say we're looking at about 40% now that have employed physicians that are allowed to own in the ASC. Super important, right? And because that is opening up, many of those that are allowing their physicians to own in the ASC are still putting it on the contracts that you can't, so they have control. So first off, push that and help that become a recruiting tool. If that becomes a recruiting tool that hospitals can use, those already employed physicians will have an opportunity to own in an ASC. Typically, it's a 51% with the hospital, but still put pressure on that point. I think it's super important. And go ahead.
Just a question to your point. If the hospital that you're going to go work at says, well, you can have your pre-existing shares in an ASC, but you can't buy more, any kind of tricks or language that you would kind of say, well?
Yes. Understanding, I'm maybe a less corporate version of my colleague here. I was raised by physicians, and I like to say I was raised by wolves, so I act like a wolf sometimes. I would be exceptionally direct and say to them, number one, the competition across the street isn't telling me that, right? And number two, your ability to hold me to you with a non-compete is gonna disappear. And as that disappears, you want to make me happy. And what makes me happy is having control of my ORs. I mean, this is a happy man who has amazing control of his ORs, right? That is the difference between going home at night happy and sad. And I'm telling you, across town, there is a hospital. They're opening up on it. I would hold firm to that. I would be direct to that. And I wouldn't let them push you. You are more powerful than you think you are. This room, joint docs, super powerful. Don't act like a primary care doc, right? Put your shoulders back, do that warrior pose that Ted thing says, and push back.
Can I say something?
Yeah, go ahead.
When you're coming out, choose your partners wisely, right? Because when I came out, we're part of this multi-specialty ASC. We can't get rid of those partners, right? We want to be just orthopedics, but we can't because they started off having, a multi-specialty approach. But, as time goes on, what we're trying to do is gain control and just not allow new partners from ENT and opto to come in and stuff like that. So.
Yep.
I think two things are important when you're looking at practices. Number one is, well, you brought this up, are they involved in private equity? That should be a gigantic red flag to you. I don't care what anybody says in this room, private equity is the worst thing that can happen to joint surgeon orthopedics. It's going to kill it, right? So if you're going to join a practice that's already done private equity, that's a big error because you're going to be beholden to bankers, which is not a good thing. Number two is, you got to know what their distribution looks like, right? How do they distribute the money, right? How do they distribute their shares in your surgery center, and when do you theoretically get involved in that process, right? I think the number one thing that when I got out of fellowship, I'd be looking at is, what is my potential in an ASC? It's not what my guaranteed income is for the first 2 years out in practice, which is going to be important to you because you still drive a Honda, right? But in the end of the day, most important thing is your potential income, right? Long term. And the only way we're going to make money is at a surgery center. The only way you're going to make money is at a surgery center.
To support what he just said, I get about 2 calls a month from an orthopedic physician that says, I got involved with private equity. Can you unwind it? Can you take it back? Can you help me? And the truth is, not really. I mean, they're pretty good contractually locking you in. So there's a lot of support out there of physicians that are unhappy with what they've done.
Yeah, and the only other thing that I'll add, for fellows considering, where to practice is going to be your geography. I think if you're working for a medical group, I'm based in California, so we have a foundation model there. The perception from the foundation models there is that you've approached them because you're maybe less entrepreneurial. You want to clock in at 8, you clock out at 5, everything is set up for you, and they don't view you as a very entrepreneurial physician. So it's just a matter of picking your path. If you have a desire to be independent, if you have a desire to be involved in ancillaries and be involved in surgery center ownership, then the independent path is the way to go. So understanding that going into the practice is key. To answer your question, once you enter the foundation model, once you're employed by that medical group, it's very rare to find a health system in the US that allows you to invest in competing ASCs. They might allow you to do so in an affiliated ASC where they've got some ownership, but very unlikely that they're going to let you own in the ASC.
Good. Any other burning questions from the audience? Okay. What I'll have you do, let's do 30-second kind of wrap up your just overall thoughts on kind of the ASC space or outpatient space, efficiencies, whatever you want to kind of leave the audience with, 30 seconds. We'll start with Dr. Suarez and go down.
So I think that, one theme that you'll see here is that all these people lead by example. And, if you're one of those surgeons that's waiting in the OR lounge waiting, and you're not leading the team, that's what you're going to get. So you got to lead by example, and they'll follow.
Great.
Yeah, ASC is the future. You just need to develop your practice, and like Charlie says, set your routines and get them down because you're going to be happier there. You're going to make more money there.
I think it's the space that is probably the hottest in healthcare right now because it's right for patients, it's right for physicians, it's right for payers, maybe not hospitals, but I think we're all seeing a transition now in hospitals and culture. And so I think it's a space that if you're not at least engaged in, you're missing a big future aspect.
Cool. Thanks, Sarah.
For me, the most important thing is being able to control the care that I can deliver to a patient. We can't control the care we deliver to patients in hospitals. There's too many variables that we can't control. If you own an ASC, you can control that patient care, which is the most important thing to us.
Great.
I would say that the key thing here is that the shift from the hospital outpatient to the ASC has already begun and is accelerating at a pace that cannot be stopped. COVID accelerated that, 10x, and now those patients are out of the hospital. Do not allow them to go back into the hospital. You've got a captive audience now, and I think as you look at your ASC strategy, your ASC ownership, make sure that you're providing efficiencies, that you're making the patient the central point of care, and I think things will work out very well for you. But it's a great time to be in the ASC space on the outpatient side, and if you have an entrepreneurial bone in your body, it's a great place to be with orthopedics, the practice, and the ASC.
At the end of the day, we're still surgeons. We take care of people. I think surgery and taking care of people has nothing to do with speed or volume, but efficiency allows you to indeed do more cases, do it better and more reliable. That's the reason why I do it, and in an ASC it's much easier to indeed introduce this and reduce the variables. That is, I think, for me, the take-home message.
Fantastic. So thank you all for being part of this. Thank our panelists.